Hello, and welcome to our first installment of the Texas 4000 Speaker Series. This is an opportunity to hear firsthand from doctors and cancer experts about a variety of topics. I'm Ryan Logan, the 2021 Programs Chair, and today we are joined by Dr. Michael Pignone from Dell Medical School to hear about the importance of cancer screenings and prevention. Dr. Pignone is the chair of the Department of Internal Medicine and the director of the Program on Cancer Prevention and Control at the Livestrong Cancer Institute. Thank you so much for joining us, and the floor is yours.
Thank you, Ryan. I really appreciate you all having me and look forward to talking about cancer prevention and control. So I'm going to really just spend a few minutes talking about the very basics of cancer screening, and I want to make three key points. First of all, apart from COVID, we have a lot of room to move in implementing evidence-based cancer screening and prevention in the United States. For none of the recommended services are we really reaching all the people in the population who could benefit from them. And not surprisingly, the most vulnerable populations, older people, people from race or ethnic minority groups, people without health insurance are the most likely to suffer from not receiving evidence-based cancer screening and prevention services. That said, this has been a uniquely difficult year, and the healthcare disruptions from COVID-19 have made what was already a suboptimal situation even worse. So this has been a year where we've really been challenged to continue the pathway to reducing the burden of cancer in our nation. And while that is the bad news, the good news is the disruptions of COVID-19 have also offered us an opportunity to get out of some old practices and try some innovative things that might have benefit beyond the time of COVID-19 for helping better deliver cancer screening and prevention services and closing gaps in care, particularly the increased use of telemedicine. So when we talk about evidence-based cancer screening prevention services, I wanted just to kind of level set about what that would mean. So I show here in this table the cancer screening and prevention services that apply to average risk U.S. adults. And there are really several strongly supported screening and prevention services. The first of which, screening for risky drinking, may not seem like a cancer prevention strategy to you guys, but we know that alcohol use, particularly excess alcohol use, is associated with a number of different cancers, including breast, colorectal, and head and neck cancers. So screening and then treating people who are using risky amounts of alcohol is a cancer screening service that we want to really apply to all adults over age 18. For breast cancer screening, we're really talking about mammography every 1 to 2 years in women 50 to 75, and then possibly extended to women 40 to 49 as well. Cervical cancer screening with testing for the human papillomavirus and doing cytology, which is commonly known as pap smears, now every 3 to 5 years, and now starting at age 25 to age 65 is also a recommended service. That's a more narrow range than had been recommended in the past. Colorectal cancer is the area that I've done the most work in, and either stool testing performed annually or colonoscopy every 10 years for men and women 50 to 75 has been a strongly supported service. And then recent evidence has suggested adding the 40 to 49 age group into that. And then lung cancer screening for high-risk smokers and smoking cessation counseling in any current smoker are also very important. And just to make sure everyone's on the same page for terminology, when we talk about screening, we're talking about systematic detection of disease in people without symptoms. People that are actually having symptoms that might be attributable to cancer, that falls into the diagnostic realm. That's not what we're talking about today. We're also not covering particular populations that might be at extremely high risk of a given cancer. We can go to the next slide. So when you look at cancer screenings in the United States during 2020, it's not a pretty picture. These are graphs that go across time. Breast cancer screening in the top row, colon cancer screening in the middle, and cervical cancer screening below that. And you can see that as you move into the year, things are kind of pretty much normal. And then you have this huge gap in screening that occurred in the, starting in the spring when COVID started to become a problem, and really not resolving back to normal until the fall because of really just disruptions in outpatient clinic visits, fear, and then some real legitimate concerns about safety and the availability of PPE in the initial period of time of the epidemic. The good news is that going to the doctor now is very safe. Our doctor's offices have sufficient PPE, and you're not likely to get COVID at the doctor's office. In fact, it's one of the safest places you can be. So even before we have vaccine rolled out, I really feel like we can get back to doing most of the cancer screening and prevention services that we delivered previously, because we now are able to ensure a safe environment. So we do need to make up, though, for that deficit. So what can we do to make up for that deficit? Well, there's a couple things we can do. First of all, let's work to end the COVID epidemic. And, just this week with the rolling out of vaccination, I think we can see the light at the end of the tunnel. That's going to make things easier and better altogether because it will allow us to focus back on the health problems that existed before COVID. Right now, COVID appropriately is taking much of our attention. Continue to ensure safe access to healthcare through good PPE. And then on the more innovative side, utilizing home-based services. So one of the things that we learned during the height of the reduction in clinic-based visits is that we really could convert to telehealth. We've been talking about telehealth for many, many years without actually implementing it. Meanwhile, this year, we were able to, really turn on a dime and move most of our care from in-person to virtual. And we found that it has a lot of advantages for patients. They don't have to overcome transportation barriers. They can integrate their healthcare visits and their cancer checkups within their usual workday. And then, on a slightly more interesting technological front, this has been accompanied by more and more advances in diagnostic testing methodology that allow us to do tests at home. So we can, do many of the tests that used to require coming into the doctor's office, including testing for colorectal cancer, testing for cervical cancer, and even, of course, assessing alcohol and smoking risk via telecare. And that way, work to reduce the burden of cancer outside the four walls of the office. The other thing that I think is going to be important going forward, and I really wanted to focus on, is that if we can do more care outside the office, we can focus that outreach on those who have the highest need and the highest risk, particularly those who are chronically underserved and have the most barriers to seeking care. So if you're someone that has transportation barriers, or you can't get time off of work to go to the doctor without losing your wages, using telecare may be one way to overcome some of those barriers, especially if we can do so by bridging the digital divide and making sure that everyone has access to good home-based internet service so that they can take advantage of not only audio calls, but also video visits as well. So all those things are, I think, innovative and promising ideas for how to reduce some of the gap in cancer care. I'll stop there and be happy to take any questions from folks.
Thank you so much for that presentation, Dr. Pignone. Now we will transition to a quick Q&A session with some other members of our programs committee.
Okay, so again, thank you for the presentation. Thank you for being here. I'm going to kick off the Q&A session by kind of referencing something you talked about in your presentation. I know you talked to a degree about how there are racial and ethnic disparities in cancer screenings and, consequently cancer rates. So how exactly does race and ethnicity affect the types of cancer screenings someone should get? this is kind of asking, like, are certain races more predisposed to certain cancers? And how should we, structure our care accordingly?
Yeah, thank you for that question. So this could be a really long discussion. I'm going to give you the short version of the answer. And then if we want to talk about it more, we can. So first of all, race is really not a biologic construct. What we call race is mostly a social construct. So there's not like inherent, for the most part, there's very little inherent biological difference in risk for cancers. Most of the risk comes from the effects of systemic racism over time. So it's manifest through lower rates of being insured for healthcare, competing demands for accessing healthcare and things like that. So that's the vast majority of the problem that we're dealing with in the United States. Okay. Now, there are maybe some small biologic differences in a few forms of cancer, but compared to the social barriers to care and the effects of racism, they're very small. That said, one of the ways of overcoming those historic inequities is just to focus more attention on bringing care to people who have been historically marginalized. And then, of course, advocating for wider spread coverage of insurance so that access to health care because of health insurance coverage doesn't become the defining limitation. Does that make sense?
Yeah, thank you.
Yeah.
Hi, Dr. Pignone. Thank you for the presentation again. I also had a quick question. So you spoke a little bit about how during the COVID-19 pandemic, cancer screenings dropped significantly. And I would imagine, would you recommend a lot of these people to go back and make up these cancer screenings? Sometimes I feel like people think if I miss one, it's not a big deal. But since these happen every so often, I want to see what you thought about that.
Yeah. So what we would like for people to do is, if you're now out of compliance or adherence with recommended screening intervals, to get back into those intervals. I don't want to make this out to be a emergency, because it's not an emergency. It can be solved over 6 months period of time just by gradually rolling back in those tests. But if you're already kind of out of compliance to start with, and now you're even you're 3 years out from your last mammogram, then I'd say moving quicker to getting caught up is a good idea. We haven't talked about the other side of the problem. In the United States, we have almost like the worst situation where some people are getting not enough care and other people are getting too much care. And if you were getting too much care, no, I don't actually want you to go back and, continue to get your yearly pap smear, which is just too frequent. We used to think that was the right interval. It's not. So we don't want you going back for that if you're average risk. We want you to get on the appropriate 3-year interval. So it's really, it seems like an easy question, but it's actually a little bit of a nuanced question. And again, I point back to the evidence-based guidelines, and that's really where we want to be. This is not a case where more is always better, but it's also a case where there are definitely some gaps in care that need to be closed.
I also have a question and wanted to say again, thank you so much for your time. You mentioned that there's different barriers and obstacles that people face when it comes to cancer screening. And I just wanted to ask broadly, what would you tell someone who doesn't have a primary care provider or insurance, and how do they get access to screening?
Yeah, thank you, Amanda, for that question. So solving the insurance question is harder. Texas, unfortunately, leads the nation in the number of uninsured people. And that's really an advocacy and health policy and political policy question. Expanding Medicaid in our state would be the quickest way to reduce the health insurance related gaps. But if you are eligible for insurance and haven't signed up through the Affordable Care Act's healthcare insurance exchanges, looking at that and really looking at whether you can get a highly subsidized plan, in fact maybe one with no out-of-pocket direct costs to you at all, is a good alternative. All right, so that's the health insurance side. As a primary care doctor, your other part of your question is really near and dear to my heart, and we know from national data that not having a regular source of care is associated with lower rates of cancer prevention service use, but also all other forms of healthcare use. And so what I would encourage people to do is to seek out care locally, particularly from your local federally qualified health center, FQHC. FQHCs or other community health centers are a great source of care, whether you have insurance or not. And they've really been the backbone of care in our community here in Austin for people who are uninsured or underinsured, and provide great care, and I think really are a still not fully tapped resource. But I would really encourage people to get into that care through primary care, and then work with their primary care provider over time to make sure they get the right services. So thank you for that question.
Thank you for your answer.
All right, I'll go next. What would you say, what would your advice be in terms of reducing the stigma around certain types of cancers and cancer screenings that we talk about, whether that's talking about colon health or testicular self-exams?
Yeah, so interesting, two kind of different examples. So one of the things that I really wanted to emphasize here was evidence-based cancer screening services. And you've really kind of picked the two ends of the spectrum. So colon cancer screening has been well proven in randomized controlled trials to be an effective way of reducing colon cancer mortality. And so, what we try to do as primary care doctors is really just destigmatize talking about your bowels. And over the course of my career, this has really come a long way. And a lot of that came through activism, particularly by two people. Hillary Clinton was very important in moving colon cancer screening forward when she was first lady during Bill Clinton's presidency. And then also Katie Couric, the former Today Show host who lost her husband to colon cancer. They've done a lot to bring that topic kind of into public discourse, and it's made a big difference in terms of, I think, reducing people's uncomfortability with talking about their colon or their bowels. So that's one that I think we've made a lot of progress on, and not nearly the barrier that it was 20 or 30 years ago. Testicular cancer. So testicular cancer is not a screen amenable cancer, and the part of the reason for that is that when testicular cancer is diagnosed, it's incredibly treatable. So you can't really produce enough benefit from detecting it early as opposed to detecting it at the normal time that would be detectable by clinical symptoms. So we don't recommend regular testicular self-exams. There's really actually very little on the screening side that you need to be doing at college age or soon thereafter, other than Pap smears or HPV testing starting in the mid-20s. On the other hand, while that's true for screening services, not drinking risky amounts, not starting smoking, or if you've started either one of those, moderating your drinking and smoking are really important factors for reducing your future risk of cancer down the road. So that's the place where I'd put your energy when you're young, along with, of course, obesity prevention and making sure you're getting good physical activity, like riding your bike 4,000 miles. Those are all really good things for reducing future cancer risk by preventing obesity or addiction to tobacco or alcohol. And all of them will have dividends that go far beyond cancer. So that's not even the only reason to adopt those healthy lifestyle behaviors.
Awesome. Thank you.
I have another question real quick. So, when we talk about screenings, obviously there are those screenings that we recommend getting very frequently, like every year you should ideally get some kind of screening done. But a lot of times I feel like people don't know that they need to go to their primary care physician for like a biopsy or for further screening, something like that. So in that sense, are there any kinds of self-screenings that we can do at home that will tell us that we need to go see our primary care physician in order to get a more advanced medical scientific screening done?
Good question. Not so much right now. I think you will see in the next 5 years more of those kind of self-administered tests coming on board. I referenced that in my talk. There are more technologies that can be done at home, but right now, most of them are like the physician orders them and then they're done at home. And then the physician is then available to interpret the results with you. So I think that will be the case for HPV testing relatively soon. It's not FDA approved yet for home testing. So that's on the horizon. It's been studied a lot, but not been well implemented. The other one that I didn't talk about earlier that is a little bit indirect is testing for hepatitis C. So hepatitis C is a viral infection that can cause cirrhosis and liver cancer. And there's now a home-based test with like a finger prick you can do for hepatitis C testing. But I still think mostly those tests are best used in consultation with your regular provider in some kind of ongoing relationship rather than on your own.
Thank you.
I think I've got the last question. I just wanted to ask, are there any screenings that you feel like are more unknown to the population and you want to talk about right now?
Yeah, 20 years ago, I would have said colon cancer, but I think we've made some progress in that direction. The one that doesn't apply to a huge number of people, but it's really important, is lung cancer screening. So we only recommend lung cancer screening in high-risk smokers. That's people who have smoked so that they've had over 30 pack years, meaning like a pack per day times 30 years or 2 packs per day for 15 years. And for those folks, getting a regular CT scan to look for lung cancer has been shown to reduce lung cancer-related mortality. So for the right people, that's a very effective and underutilized service. And then, like I referenced earlier, just the relationship between alcohol and various types of cancer. I think very few women recognize that risky drinking, which for women, really more than 1 drink per day, does have associated risk for breast cancer, in addition to some of the other cancers like liver cancer, head and neck, colon. And, that's something that we should be factoring in. I think particularly during the time of COVID, a lot of people have increased their drinking. And, that's not great for your health in the long term. We really want people to kind of stick to the less than 2 drinks per day for men, 1 for women. At that level, there's very little associated adverse risk. But as you start going up, that risk increases, obviously. So that's the other one that I just want to put a plug in for.
Thank you.
Mm-hmm.
All right. Well, I think that just about wraps us up. On behalf of all of Texas 4000, thank you so much for making the time for us and sharing all that truly vital information.
It's been my pleasure.